Welcome to the Hazard Class Podcast. This is the podcast where I get to ask my stupid questions to some of the smartest people in and around the world of emergency services. My guest this week is a licensed clinical social worker who is nationally recognized suicidologist with over 15 years of experience supporting law enforcement, first responders, and veterans. She is the former director of psychological health for the Minnesota Army National Guard. She is a Minnesota Veterans Affairs suicide prevention subject matter expert. She is the owner of the Minnesota-based therapy center Wellness That Fits that exclusively serves veterans and first responders. Wellness That Fits is literally where I go to therapy, and I encourage everyone in the community to prioritize their mental health and well-being, even if you feel like it's not something that you need to do. It's done a lot of good things in my life, and I encourage everyone to do it. So with that said, it's my pleasure to talk to my friend and my guest this week, Dr. Brittany Miskowiec. Brittany, welcome to the show.
Thanks for having me.
Of course, yeah. I appreciate you taking the time out of your day to come and chat with me. So as is the format of the show, we start each episode out with our wheel of stupid questions. Just a reminder that if you ask questions, even if they're stupid, if you point them at the right people, you can get some pretty smart answers. And I wanted to touch on this, right? I'm having you come on to talk about some pretty heavy subjects. And, originally I was like, well, am I going to do the stupid wheel? And I ultimately decided, yeah, we are, because I think that the idea of destigmatizing these topics and not making it so taboo is important. So even if we're going to talk about a heavy subject matter today, we can still start it off with a little bit of fun and silliness and have it be normalized, right? All right, so we're going to hop into the stupid wheel. That. Sounds good? All right, it's time to spin the wheel of stupid questions. We're going to see what we get this week. Oh, this is a new one. We haven't had it. I'm going to be shocked if you have one. Dr. Miskowiec, what is your zombie apocalypse plan?
Phone a friend? No, I think it would probably be phone a friend who has a plan, because I don't. And I'd be screwed.
Yeah. Well, hopefully your years of working with veterans and first responders would come in handy. You could have a few friends to phone.
Yeah. As I'm thinking about it, there are definitely some people that I would call. Some others I would be scared to call.
There's probably some people that are maybe too prepared, I would say.
Yes, very much so. Oh, that's a funny question.
It's a stupid question, that's for sure. All right, let's get into the real nitty gritty. So Talk to me about your history. How did you become this person inside the world of suicide prevention?
It's kind of a weird story because I didn't mean to. My first internship in my Master of Social Work program, I was supposed to be in a school. I was supposed to, be a school social worker, essentially. And I got there to the school the first day. I was super excited, went to the principal's office. They told me to wait outside for the social worker to come get me. And I sat there for about 30 minutes, which anybody knows me, it's so patient for me to be there for that long and not say anything. Mm-hmm. And then it kept going, and they kept telling me to wait. And ultimately, the social worker quit and didn't tell anyone. Outside the principal's office for hours, and then they were like, sorry, we don't have anything for you. And so I had to go back to my university, and they said, well, the only place we can send you is this crisis center, because they always need people there. And so I went to the Baton Rouge Crisis Intervention Center, and there I worked the National Suicide Prevention Lifeline. I co-facilitated a survivors of suicide support group and a children's bereavement group. And I also was the first intern that ever volunteered with a LOSS team, which is local outreach to suicide survivors, where we practice active postvention, actually going to the scene of suicides. And I ultimately ended up directing that team. So, my my first internship, my first clinical experience in the social work field was 100% suicide. And so I kind of just got thrown into it.
Wow. Talk about jumping into the deep end of social work. Holy cow. So from that point, how did you make the leap then to going from, general populace to first responders and veterans focused?
Yeah, that was kind of a weird thing how it happened when I was in Baton Rouge doing the loss team. It was essentially a peer support team, people who had lost someone to suicide, were at a good point in their grief, and then went through training to be able to support others. So I was the clinical director of the team. So I would go out to the loss calls, but nobody wanted to talk to me. They wanted to talk to the person who had been through it. So I would end up standing, off to the side on the street with the first responders, and made some connections there. And I did a little bit of critical incident response stuff down there with fire departments, really. And then when I moved up to Minnesota, I took the job as director of psychological health with the Army National Guard. And pretty quickly realized that in Minnesota, there is so much crossover between the Guard and first responders because we don't have an active duty base here. And we have a pretty large National Guard population. So it was kind of just natural to put those two together. My husband is a paramedic himself. My brother is a cop down south. And I have a lot of really good friends. My best friend is a veteran himself. And so, yeah.
Yeah. So the one thing I always wonder, especially as someone who was a first responder. Also, for those who don't know, I had a brother who died from suicide, and so suicide prevention, suicide has just been a part of my life growing up, right from an early age. And so, is PTSD and suicide a problem that's growing, or is it just that awareness to it is growing? That's an interesting thing to me.
Yeah, I mean, if you look at the suicide rates over time, the rates they've grown a little bit, but there has not been a huge change. I think there's a lot more awareness of it. And to be honest, I think there's a lot more awareness of everything over the past few decades, just with the growth of social media and technology. We have everything at our fingertips, and not only is it easy to find things, but things are kind of thrown in your face when it's on someone's agenda. And so I think we are more aware of it, but the suicide rates they've increased slightly over. It's not been a dramatic growth.
Yeah. When we think about suicide and suicide prevention, is there some sort of correlation that we see from a root of like these deaths? Is it like, there's some like similar factor that comes in all these things like that we can track it back to?
Yeah, that's a really good question. I think that's one of those questions that I get asked about suicide that if I knew the exact answer, I would probably be a millionaire somewhere and live on Disney World's grounds, because I'm one of those people.
Yeah.
Because, we don't know for sure. There are absolutely, risk factors, things that increase people's risk. And one of the things that I do, and this is kind of where this comes in, I'm certified as a psychological autopsy investigator and retrospective fatality analyst. And what that means is that sometimes we're called in, and it could be from family members that request it. It could also be from agencies as a whole that request it, but in-depth investigation after someone dies by suicide. And we have a protocol of about 330 questions that we ask the people who knew the person most closely. And we try to develop a timeline of events that occurred and also answer the questions, why now, and what could have been done to prevent it. And think back to when I worked for the Minnesota National Guard here. We did a very mini version of that, and we looked back at, I think it was over a 20-year period. I'd have to verify that, but we looked at all of the suicides and kind of looking for that information. What's the common link? And I think it's a common thought is that people, especially with the military, associated with deployment. And when we did that research, it came out to be that 51% of the people had not deployed and 49% had. But the common factor amongst all of them, not all of them, I'm sorry, the most common factor amongst the group was adverse childhood experiences.
Wow.
And so that stands out a lot. And if you don't know anything about ACEs or adverse childhood experiences, it's super interesting to look into because the more that you have, it increases your risk of so many things, not only mental health, but your physical health.
I believe that I've taken that for, is that like, it's like, I don't know, 10 questions or something like that. You get scored 1 through 5 or whatever it might be.
Yeah, it's a 1 through 10. So it's got these 10 questions. Then basically, I think it's 3 or more. If you've had 3 or more, that's sort of the baseline that with that number, it increases your risk. And then the more you have, the more it increases your risk.
So with that, that's called ACEs. With that
Adverse
test,
childhood experiences.
okay. With that, what are the specific things that it increases your risk for? You said suicide. What were the other ones?
There's a lot of different health conditions: heart disease, diabetes, stroke. A lot of medical conditions. And who I don't know, but I always say she's one of those people I want to be when I grow up. Her name's Dr. Nadine Burke Harris, and she's a pediatrician out in California. And she has just the most eloquent way of describing it in a TED Talk. And she explains basically that, your body is set up to experience trauma and danger, and that's great. It's great that if you are in the forest and you're face to face with a bear, your body goes into fight, flight, or freeze mode, and the amygdala, which is the alarm center of the brain, starts pumping adrenaline and cortisol, and that's great if you are face to face in the forest with a bear. But if the bear comes home every day, and your body reacts to that and starts pumping the adrenaline and the cortisol when you are a child and developmentally, physically, that's an important time in your life. It impacts you long term. It has a lot of negative long term health detriments.
Wow, that is insane. So
it really is.
If we think about this from a more tangible perspective, say from not only personally, but in monitoring our peers, as I would hope that we are doing, what are some kind of early warning signs that we could be looking for in behavior or statements, things like that could potentially trigger, myself, both trying to look at myself or looking at my peers to say something might be off?
I think the biggest thing is change. It's really what all of it boils down to, because, you can look at all the warning signs of increased alcohol use, isolating from peers, no longer doing the things that you enjoy, becoming increasingly angry or more irritable. All of those things are changes in the person. And so, I really boil it down to that. If you notice that someone has some type of behavioral change, it's worth checking in with them about. And it may not mean they're thinking about suicide, but it means that something's going on.
So I know we're focusing the vast majority of this on suicide, but I also want to touch on PTSD because I know that you're also well-versed in that too. So do we see a correlation directly to PTSD rates and suicide, or a connection between the two, or is it kind of like two arms of the same monster?
That's a good question. I'd have to go back and look at the research in terms of correlation, but I mean, any type of mental health diagnosis is a risk factor for suicide. I will say in the population that I serve, I don't necessarily think that there's that more of the people who are diagnosed with PTSD have thoughts of suicide.
Interesting. I think that's super interesting because I feel like from a front-facing perspective, from a perspective of a person in the industry, when we have, like, I've had coworkers take their own lives, and it seems like the go-to response is they had PTSD, they had committed suicide, right? It's like that fast but to hear that maybe they're not correlated that way, it could be, but it's not necessarily one or A equals B, is interesting to me. Would you agree with that statement, or is it not true?
Guess, it's really hard to say, and I'm thinking about my group of clients that I work with, and anybody that comes to Wellness That Fits has got something going on. They've got symptoms of something. So I'm kind of comparing like the PTSD group and then all other diagnoses groups, kind of comparing the two. And I will say that I'm a little stingy with my PTSD diagnosis because it is a lot harder to diagnose somebody with PTSD than typically people think. Especially in the first responder world. I think there's just this gut response to when someone experiences a trauma, oh, they've got PTSD. And just because you've experienced trauma doesn't mean that you've got PTSD. You likely have some type of post-traumatic stress afterwards. You're probably going to experience some PTSD symptoms. But to actually get a diagnosis of PTSD, there has to be this certain amount of time that's passed. And you have to meet criteria in so many different categories. And what I typically see is that people's symptoms are clustered within one category. For example, one of the categories is avoidance. People avoid going down a certain street or going to certain places. All of their symptoms might be clustered there, opposed to the intrusive symptoms, which might be, people not being able to think about anything other than that.
Yeah, that's a really interesting thing, and it actually brings up this thing and I want to ask you about your methodology, because one of the things I love the most about you is that you kind of, in your own terms, cut the bullshit when it comes to talking about some of these things. And I feel like so much now people are just so willing to throw these labels on people of, oh, PTSD or traumatized or whatever the thing might be. But you're willing to say, hey, it's more of a nuanced thing than that. There's things we can do to get through this. Talk about your idea of, and especially when you're dealing with these populations, which you focus on, shooting straight versus kind of like this fluffed up, psychologist talk, right?
I mean, it depends on why the person's coming in. I try to, at all costs, really even put a diagnosis on it. We're working with health insurance. We have to, which sucks. But, somebody comes in with issues and symptoms. We're addressing the symptoms. We're working on that. Now, some people, it's really important to them to understand, like, this is my diagnosis. This is what it means. And so for those people, like, I'll sit down on the sofa with them with the DSM and look at it line by line. Like, I've had some people where that is what they need, but every client has such a different set of needs, and we're really looking at the symptoms of it. And now I'm going to go back to what I said, because now I'm getting all in my head about the diagnostic thing, because here's the big thing that really bugs me about the PTSD diagnosis, because I do think it is way overdiagnosed in our first responders. And don't get me wrong, you see shit every single day that other people shouldn't see. Like, I get that. You were exposed to trauma on a daily basis, but it doesn't mean you have PTSD. And with any mental health diagnosis, part of that criteria, like the very last criteria for everything, is that it has to impact your ability to function in some area of your life, either at home, at work, in your relationships. And so just because someone is having nightmares, let's say somebody has nightmares about a particular call once every couple months. They have a nightmare, they wake up, they're able to go back to sleep just fine. Is that impacting their ability to function in life? I mean, for that person, it may be,
Yeah.
but not necessarily.
So then what is, sorry, I don't want to cut you off, but I want to ask you a specific question about that. So then what is their ailment? Is there another word? Is it just we're using PTSD too broadly and there's another word that goes for these like intermittent issues that someone's suffering from?
I mean, I think it's all, I hate to be the one to say this, but it kind of all occurs on a spectrum.
Yeah.
And, you're exposed to trauma. And then there is a period where you have a normal response to an abnormal thing that you experienced. And so for the first like 6 to 8 weeks, it's normal for you to, be a little bit more irritable, or you're not sleeping as well, or where, you get a little bit anxious before you go in for a shift. Like all of those things would be normal within the first 6 to 8, up until that 6 to 8 week mark. At that point, if those symptoms continue, that's when we start to explore the possibility of PTSD.
Mm-hmm.
But like I said, there's still so many criteria that you have to meet. And regardless of whether you meet full-blown criteria or not, if you have symptoms of PTSD, it fucking sucks.
Yeah.
Who gives a shit if you have a diagnosis or not?
Yeah. Yeah.
If you've got the symptoms and you're struggling with the symptoms, go see someone and take care of it. And I think we focus on that actual diagnosis too much.
Yeah. So that brings me to my next question, which is, so say we've recognized something in ourselves, or even more specifically, we recognize something in someone else. What are some of the best ways to approach that person to either not confront them, but breach kind of a difficult subject, talking about PTSD or suicidal ideation, something like that, with someone that you suspect might be suffering from something like this?
Yeah. So the way that I kind of learned to ask the question, and I put it into a formula really, where you show someone the evidence, you normalize it, and then you ask directly. So I might say, look, Jake, I've noticed lately, you've been showing up for work a few minutes late. You've kind of been a little short with everybody around here, a little bit more irritable than usual. And I know you've got some issues going on at home with your kids. And in any of those situations, somebody might be considering suicide. So I want to ask you, have you been thinking about suicide?
Mm-hmm.
And
I understand, based on some of the training I went through, that like that blunt question is important to the process, instead of just kind of beating around the bush, like, how are you doing? And so can you kind of speak to that, I guess, the reasoning for why that's so important to be blunt?
Yeah, to be direct about it. And using the word suicide is important. You won't talking about it, or at least appear comfortable. It might be an uncomfortable thing for you to ask, but at least appearing like you're comfortable talking about it is going to give them permission to be honest with you. And, being direct about it also does not leave any room for misinterpretation. There are some people who will ask, are you thinking about hurting yourself? And if you ask somebody who's thinking about suicide that question, in their mind, it could be that that's not going to hurt. This is what's going to take away the pain.
Yeah.
So it's not something you want to mess around with. Like, you want to be direct, be confident, and let them know I'm willing and ready to have the conversation.
So then let's go the next layer further into the conversation. Obviously, you said you worked on suicide hotlines before. Obviously, if you had this conversation, you need to be prepared for them to say yes. So now what's the advice? So now you have your coworker, your friend, your family member says, yes, I am thinking about, committing suicide. What's the next step?
What would your genuine response be if somebody said yes to you? Like somebody you care about?
Like
in your head, what is your first?
I I don't know. It gets really close to the heart for me. Obviously, I have with my brother, but it's um, wanting to be with them and stay with them and support them and let them know that they are loved and wanted, and they're not in it alone. I suppose is kind of what resounds to
Yeah.
me.
Yeah. And what I heard you say too, like underneath all of that was, damn, that's a lot for me to hear, especially
Yeah.
because I lost my brother to suicide.
Mm-hmm.
And I think that's what you can say, Jake, is just you want to be genuine with the person and just respond genuinely. And if that's your response, like, holy shit, that's actually a lot for me to hear. And when you said that, it really hit me.
Mm-hmm.
I'm here for you. I want to talk. And that's the biggest thing, is to be there and to listen. And that is, one of the things that people miss so much. And we teach this in a 2-day suicide intervention class, which is the listening part. We tend to jump straight to solving the problem and wanting to fix it or talk them out of it. And I always say, I think the coolest thing about suicide prevention is that most people can talk themselves out of it if they're given an opportunity to talk about it.
Mm.
But most of the time, we want to jump straight to the end to fix it for them or solve their problems. And so, if you can just sit and listen to their story and hear what's going on, a lot of times that's part of what they need.
Mm-hmm.
Now, of course, there's this other element, which I'm sure you're going, holy shit, why isn't she saying, like, shouldn't the next question be, do you have a plan?
Yeah, that's definitely one of them. Yeah.
Yeah, and that is one of them. There's the, are you thinking about suicide and do you have a plan? Those are kind of the two questions. And I think there's question 1 and then question 1.5 is that whole like listening. You're just engaging and hearing their story. And when you feel like it's appropriate, ask them if they have a plan.
Yeah.
I discourage people from, and are you thinking about suicide? Well, do you have a plan?
Mm-hmm.
Have you thought about how you're going to do it, where you're going to do it, when you're going to do it? Not an interrogation.
Yeah. When I think about that conversation, it feels really overwhelming, and I'm sure a lot of my peers feel the same way. You being someone that's probably had that conversation more than 99% of the population, have you found like I don't want to minimize it by saying like tips and tricks, but like have you found any like pathways through that conversation that have been better than others?
Yeah, I think just, for one, remembering that if you have the luxury of time to sit and talk to someone and they're in front of you and they haven't taken any pills and don't have a weapon in their hand, they are safe. Somebody would have told me that 15 years ago. Once you realize that, it's like you can just take a huge deep breath and go, okay, we're just going to talk. And at any point, you can always phone a friend. And 988, which is the National Suicide Prevention Lifeline, you can always call that phone number and say, hey, I'm with a buddy. They just said they were thinking about suicide. I don't know what the hell to do right now, but they're willing to talk to you and hand over the phone. So
yeah,
the tips and tricks part, I think, is remembering that if they're in front of you without pills or a weapon, they're safe. Be genuine and treat it like any other conversation. And remember that there are always resources that you can bring in and connect with for additional support.
So as we look forward kind of in the future of this field, and the future of my field too, is like, is there any end to the madness, or is the field kind of, that being first response and, veterans, is there any sort of cure or respite that's coming, or are we just kind of cursed to suffer these ailments at a higher than normal rate based off the work that we do?
I guess I never really thought about it in those terms, but there's always going to be shit out there.
Mm-hmm.
You're always going to be responding to other people's trauma.
Yeah.
If you get into that line of work. And so, unfortunately,
the reason that I asked that is because I think that some of the narratives that come out in regards to mental health, PTSD, more so PTSD than the actual suicide issue, is that like some people want to make it seem like these career fields are like going to be able to solve this problem. And I personally believe that there's just like the same way that I, understand that when I decide to be a firefighter, I have a higher than normal risk of getting cancers in my life. And I have to take that on with the career. There is a certain element of PTSD, mental health issues that you say, okay, I'm going to expose myself to a greater risk. So if I'm going to do that, then I also need to maybe, seek mental health services, like going to therapy preventatively or whatever it might be, because this is a thing that's not going to be solvable from just like talking about it. Like it's going to be inherently a part of this career field forever.
I agree with that. I think it is inherently going to be part of the career field. And I also think that there are also things that can be done about it. And I think we're finally getting into this prevention mode a little bit more. Like right now, 2 of our therapists are at a police department academy, and they're doing 2 hours of wellness right now. And we have a total of 8 hours with this particular academy throughout their training, where we are talking about officer wellness for them, building their resiliency skills before they even hit the street, so that they know what to expect, what to look out for. We give them tools and things that they have in their back pocket. And they also get to meet 6 therapists that work with law enforcement throughout their academy. Does happen, they've got those connections made.
Yeah. So I've seen your curriculum before, and I know that it's different than others, but I can tell you that the vast majority of my listeners are hearing that you're coming to the academy to give a mental health presentation, and they're rolling their eyes because they think it's going to be the same HR presentation that they've seen a billion times about, like, don't feel sad kind of thing. So can you talk about how you offer those services that's different than how they've been offered traditionally?
Yeah, I mean, it kind of depends on how much time we have. Like, I don't want to name particular agencies, but like on one side of the river here, we have 5 full days throughout their academy. That's huge. Like, to think we get that much time with them beforehand. On the other side, we've got 8 hours. And so when we do the 8-hour curriculum, it's broken up over 4 2-hour classes. And we start with an individualized wellness assessment, or like they look at the 8 dimensions of wellness for them and they score themselves. And then we talk about each one of those dimensions of wellness throughout our time with them. And in the end, they do a reassessment to see if they've improved their score at all throughout the academy. And for some of them, it's not going to move. For others, it's going to drop. And for those people, I kind of challenge them and say, well, what the hell do you think your score is going to do once you get into FTO?
Yeah.
Like, it's not just going to go up. So if right now during the academy, you can't increase your wellness, maybe a little concerning. And maybe you should take a look in the mirror.
Mm-hmm.
So we do a lot of practical application. We've got, we've got a PowerPoint slide in the background, but we're teaching them actual skills that they can learn to increase their mental wellness.
So I didn't talk about this earlier, but I think it's, and I don't know if you'll have an answer for this question, but you talked about ACEs being kind of something that predisposes you to some of these problems. That said, are there people that just are better fits for certain career fields versus not? And like, even if you really want to do a job, it might not be the best fit for you. Or is it like you might just have to do a little extra work to make it work, or maybe this one's just flat out not going to be for you? I don't know if that's answerable or not, but
I mean, I think it's probably a combination of those things.
Mm-hmm.
You know, when therapists want to work with the population that I work with, I used to interview people, and we had quite a few therapists who I can remember interviewing. One in particular, and I can remember her because we're in Minnesota, but she sounded like a Southern woman. She was like, just bless their hearts. You know, they just go through so much, and I just want to help those firefighters out there.
Mm-hmm.
And I was like, lady, they're gonna eat you alive. Like, you might have this sweet little heart that wants to support them, but like, no, you are not a good fit for this.
Mm-hmm.
So I think about that even on our side. There's some people who are just not a good fit for this work.
Mm-hmm.
And yeah, I mean, same in the first responder world. Everybody's different. I started my career with suicide, and my second internship was dead babies.
Oof.
So yeah, when you start your career with suicide and dead babies, it, you know, I don't know, everything after that's like, man, bring it on.
Yeah, no kidding. Holy cow. So this all boils down to the last big question, which I think if we can solve this one, makes everything else easier, which is how do we work to remove the stigma around mental health discussions and talking about suicide? Because, we're doing better than we've ever have been, I think. But still, there is a stigma that to care about your mental health is a sign of weakness, instead of the same way where someone might take pride for going to the gym 5 days a week. But if they were to confess that they go to a therapist once a week, now that's a point of weakness instead of pride.
Yeah, I think it's more than one thing. I think from an agency perspective, if we're looking at one particular agency, having access to culturally competent mental health resources that are, our approach is to be embedded without having an office on site.
Mm.
And so getting to the point where we're doing like the annual required trainings, and we do the wellness check-in so people know us. And if I'm on my way home through a city of a department I work with, I stop in, I say hello to whoever's there. So one, having access and relationships with culturally competent mental health providers. Two, having good peer support. So having some type of peer support team where there are trusted, good people on the team who advocate for mental wellness and people know that they can go to. And third is leaders. Having leaders who support this type of resource and not only talk the talk, but walk the walk, and are willing to say, been through some shit myself and I've used the resource.
Mm-hmm.
Or, I've referred others to the resource and gotten good feedback about it. And I think a lot of time the leaders at the top, they'll say, yeah, we support this. Let's write the check and get the services. But they don't talk about their own stories. And that stuff can be so impactful.
Mm-hmm.
And everybody's got something.
Yeah. Mm-hmm.
Everybody's got something that they've struggled with that they can talk about.
Mm-hmm. So as we look to wrap here, what are some resources that could be available to both individuals or on departments to, work to promote those values of, breaking the stigma, and then also just tangible things that people can look for if they're hoping to help someone who's struggling?
Yeah. So Living Works is an organization that has some amazing training. They have Living Works Start, which is a 1-hour training that you can take online that teaches you about the warning signs of suicide and how to ask the question. They then move up to a 4-hour training that's called Safe Talk. And they also have a full 2-day training called Assist, which is Applied Suicide Intervention Skills Training. So Living Works trainings and mental health first aid trainings, both of those I think are great, just foundational trainings that people can take to learn more about mental health, suicide, and how to talk about it. Culturally competent therapists for first responders and veterans are important. Here in Minnesota, there aren't a ton, but we all know each other and work together. And so knowing who is in your area that does work with these populations is important. is the National Suicide Prevention and Crisis Line. And that is a phone number you can call, you can text it, and you can talk to someone anonymously. It's just a non-judgmental person you can talk to. There's also a few other national lines for first responders. The one that I've had people had good experience with is Hotline. Some of the others, it just kind of depends on when you call and who you get.
Mm-hmm.
So just kind of Googling what's out there in terms of that.
Mm-hmm.
And if you've got a good relationship with any type of medical doctor, they can always give you referrals for mental health professionals too.
Perfect. Awesome. Well, Brittany, thank you for joining me and thank you for the work that you do. I'm appreciative. Obviously, I know you personally, so I really appreciate you and love you. But also thank you for coming on the podcast, just sharing some of your knowledge with us.
Of course. Thanks for having me.
For sure.